Thank you for the introduction. Really glad to be here, and I'm thankful for the invitation. Let's move in a different context. This is a question that can be solved very easily. Does ventilation matter in this context? The answer is yes. But unfortunately, I don't have the beautiful pictures, studies that most of the other speakers have shown to you during these days. Here, indeed, our background and our studies are relatively scarce. However, I would like to share with you some considerations. As first, we have to know that all those patients who may have an out-of-hospital cardiac arrest often die after the recovery of circulation before the hospital discharge. And the point that we have to address that there is always a combination of factors that interfere each other between the cardiac situation and the ischemia reperfusion condition that alter at the cellular level in brain and the other tissues and organs all the normal balance. And we try to find out a solution or a way to minimize the organ failure after the cardiac arrest. If you look at this cartoon, here are illustrated the complex interplay that exists between the ischemia and reperfusion phases after cardiac arrest. As first, a message that may be interesting and that has been driven by psychological reason, I would say, that most of the patients who undergo to the cardiac arrest indeed do have the administration of 100% of oxygen at the very beginning. And however, during the CPR, what we have is the low tissue blood flow. And these unavoidably shift toward the anaerobic metabolism and causes an intracellular acidosis. What happens into the intracellular and extracellular space? That there is an interchange of sodium and calcium, and finally it leads to an intracellular calcium overload. And this has an important function on the derangement that we may have of the mitochondrial function within the cell. But at the same hand, after the recovery, we have a hyperperfusion phase, a reperfusion phase, when we have a transient hyperemic phase. And that is a good, theoretically, tissue oxygen delivery with an increase of intracellular PaO2. These may go toward a different problem, which consists in the liberation of reactive oxygen species, causing the oxidative stress. And ultimately, these two conditions interact with each other. However, the reflection that I want to make together with you is based upon three main issues: the PaO2, PaCO2, and the ventilatory strategies. As you will see, unfortunately, not many papers have been published in this context. However, it is interesting to see that, in general, there are factors that prevail in the assistance to the patients after cardiac arrest or during the cardiac arrest. And in many studies, including this one, which is an observational, most of the studies are retrospective, unfortunately, on a relatively small number of patients, the common finding that emerged was the frequent use, especially in out-of-hospital cardiac arrest, of hyperoxia. And this is also very common when the patient has a prolonged time to the ROSC or there is a delayed admission to the ICU. However, when we look at the hyperoxia, there are some reports that tells us that may be very detrimental. Indeed, if you look at this large study that included more than 6,000 patients in 120 centers, and where the hypoxia was characterized by PaO2 value below 60, or the hyperoxia with a PF value above 300, looking at the hospital mortality and the recovery of the cerebral function, the percentage of recovery was quite lower respect to those patients who had normoxia. And interestingly, the final conclusion of the study is that among patients admitted to the ICU and following resuscitation from the cardiac arrest, the arterial hypoxia may be detrimental and is independently associated with increase in hospital mortality. So something that should be against, even though most of us has the tendency of use the high flow oxygen and the high FeO2 in these kind of patients. However, if you look at the characteristics of these studies, at the end you realize that there is no real adjustment for the FeO2. And the definition of hypoxemia, hyperoxemia is based on a single arterial blood gas analysis. And obviously, under these conditions, we may get a possible selection bias. However, not always we get the same results. Indeed, in this multi-center observational study, over more than 11,000 patients in the Australian registry, they've been addressed exactly the same issues, but the conclusion was totally different. Indeed, the hyperoxia, respect to normoxia, didn't show any major concern and evolution toward a detrimental effect. And indeed, there was no difference in the hospital mortality among the different levels of hyperoxia when these were compared to patients whose PaO2 was between 83 and 93. And, but on the other hand, the same study confirmed that there was a detrimental effect of hypoxia. Another point is that has been made in this other study that was recently published, where has been considered different time points and the duration of hypoxia. And indeed, what counted the most in this study was the length of exposure to the severe hypoxia. That was longer respect to the other conditions of normoxia or hypoxia. And indeed, excuse me. And in this study, the major point that after the adjustment in the multivariable model, the severe hypoxia per hour was the major determinant for the, as a predictor of the a worse outcome. And indeed, the severe hypoxia was independently associated with a decreased survival to the hospital discharge. However, also this study has some limitation, and there was a relatively low exposure in the cohort with respect to the other conditions. However, there was a systematic review, a meta-analysis on the comparison of the study where hypoxia and normoxia have been used, and the conclusion was certainly in favor of the normoxia for a better outcome of these patients in terms of mortality and functional cerebral recovers. But however, again, these retrospective study included into the meta-analysis were all observational, and these represent a major limitation. And there was no real investigation about the causal association. And the heterogeneity was there because the hyperoxia has very different thresholds. And again, as I mentioned in previous study, we cannot consider the single value of arterial blood gas analysis as a reference value. However, looking at these up to this point, we can conclude that the hyperoxia in general after the cardiac arrest may be associated with an higher mortality. And so we may just suggest avoiding it if possible, titrating the saturation something in between 94 and 98, but in any case, we have to strictly monitor in order to avoid also the hypoxia. Then let's move to the PaCO2, because also the PCO2 counts. Indeed, we have to make some, take into consideration some important elements. What happens, what occurs to the cerebral blood flow after the cardiac arrest? That unfortunately, some perfusion is not restored in certain areas of the brain, which means that you have certain area where the blood flow is preserved and other not. And this is in general proportional to the duration of the global ischemia that occurs during the cardiac arrest. In addition to that, there are some inflammatory phenomena that cause the so-called no-reflow phenomenon that is caused by the sludging of red blood cells, the edema again around the vessels and within the contents of the glia, and the adhesion to the endothelial surface of the white blood cells. There are some delayed hypoperfusion, and we know all that the cerebral blood flow autoregulation is impaired. However, what is still maintained is the CO2 response. And these may have consequences depending upon the way in which we ventilate our patients. Because in these cases, if you hyperventilate them, you may even worsen the cerebral ischemia that occurs in specific parts. In this monocentric study on almost 200 patients addressing both the out-of-hospital and intra-hospital cardiac arrest, all patients whose Glasgow Coma score was 6 or lower were included after the recovery of circulation, and was looked at the as a primary outcome, the poor neurological function. Interestingly, if you look at the neurological outcome, was much worse when hypercapnia or hypocapnia, or even worse when there was a combination of both, respect when the no hypercapnia or hypercapnia was present in the other group of patients. And at the very end, the authors concluded that both hypocapnia and hypercapnia were associated with a poor neurological outcome. And then the derangement of this parameter may be really harmful for these patients. A large survey, again, was accomplished in the Australasia by the Rinaldo Bellomo group, and over 16,000 patients, and where, again, there is a relatively new message, where those patients who developed hypercapnia indeed went better than those who developed hypocapnia. And so the concept of having a permissive hypercapnia or a mild hypercapnia in this subject developed. And interestingly, looking at a different level of PCO2, having a higher PaCO2, it represented a protective factor, and indeed seems to be beneficial in terms of outcome, mortality, and recovery of cerebral function. However, again, this is not a randomized trial. This is not a trial that can be conclusive, but there is a signal there. For these reasons, a pilot feasibility study is ongoing. And in this study, again, the Australian group is trying to compare the normal CO2 with a value between 35 and 45, and the PCO2 between 50 and 55. We'll see what will be the final results. In the meantime, however, we have to limit our consideration to what I have shown you. That indeed, again, these are all retrospective studies. And when you go deep into the real results of the study, there is no real information concerning the death. And indeed, very often, it's important to consider that the CO2 and the PaO2 not always reflect the ventilator strategies, but they are linked to different conditions. The last matter pertains to the ventilatory strategy. Indeed, if you look at the literature, there is no major paper published on that. What we may just deduct some ideas coming from other studies such as those that address the possibility of using a lung protective strategy also for patients who do not have the RDS. And indeed, we know from several meta-analyses that when we compare patients with the protective ventilation, so-called 6 ml ideal body weight, through the conventional ventilation, we have a clear-cut improvement in terms of reduction of the lung injury as well as a reduction in mortality. So we may at the end, in this sense, conclude that also applying this concept to patients who are who suffer from cardiac arrest may be beneficial. However, the only paper that may illustrate somehow how we ventilate the patients and the link that can be found between the ventilation and the outcome is this one, that indeed analyzed the evolution of our ventilatory behavior over time in 3 different periods. One in the 1998, then in 2004, and 2010, in more than 900 intensive ICUs in 14 countries. And if you look at the 3 different cohorts, it's interesting to see that the tidal volume, no matter if it is an actual body weight or the predicted body weight, had a tendency to go down over the time. And you have a higher level of PEEP, and you have a plateau pressure that was lower respect to the previous years. So in a way or another, our way in which behave with these patients respect the concept of ventilatory strategies. If we look at the different modes of ventilation, at least in the 1998, the most used was the assist control. Whilst moving toward the 2010, there started to be more used than in the past, the pressure support ventilation. But interestingly, at the end, these different kinds of ventilations did not affect the outcome, nor plateau pressure, nor the level of PEEP of these post-cardiac arrest patients. What counted the most were other factors, including the level of Glasgow Coma score and SAPTO score. I want just to conclude with this flowchart, this algorithm that has been proposed and can be practically useful. In general, when you have, after the hospital admission and cardiac arrest, you have to look at the PaO2. If it is above 300, in this case, you may titrate your VO2 in order to target to your SpO2 above 94. If the PaO2 is lower, then try to optimize your target, but it is below 60 millimeters of mercury. In this case, what you have to do is just to check the reason for hypoxia. Looking at the PaCO2, just remaining into the normocardia, let's say, you have the possibility of reducing the tidal volume in the mechanical ventilation. But in case you have a higher level of hypoxia, then you have to check for signs of intracranial hypertension, as you know. Finally, which are the potential conclusion that both PaO2 and PCO2 derangement are indeed associated with a lower survival and worse neurological outcome, that looking at the current guidelines for the resuscitation, the recommendation is to maintain PaO2 and PCO2 within normal values, non-hyper, non-hypo, and this is true for both adults and children. And indeed, we may extrapolate that the protective ventilation strategy could be useful like in all other critical ill patients, and obviously we need more not retrospective but prospective trials. Thank you so much.